neurosurgery at UCSF at the Fresno campus, which is in the interior of California. And thank you for asking me to talk. And I'm going to talk about the prognosis of aneurysmal subarachnoid hemorrhage this morning. Overall, the outcome from this disease has been improving, and this is a paper from actually a decade ago looking at the reported mortality for series of subarachnoid hemorrhage patients, and you can see that it declined from about 50% in the 1980s to now about 35%. So that's actually a remarkable about 50% decrease in mortality over 20 years. The decrease was attributed in an editorial with the article to improved diagnosis, early aneurysm repair, and aggressive treatment of complications such as vasospasm. And so we'll talk about some of those things today and how we might improve the outcome and prognosis further. Now, many papers that I review on subarachnoid hemorrhage start off with a statement about how aneurysmal SAH is a terrible disease and it's very morbid. And that is certainly true in one sense, but in another sense, I think and these patients have cognitive deficits definitely, but that is somewhat, I would say, overestimated these days, because if you look at, for example, this data from a recent randomized clinical trial where out of about almost 300 patients, you can see here, and these were WFNS 2 to 4, so we're not even including patients who are grade 1 and awake and alert. You can see that 20% of them had an extended Glasgow outcome score of 8, which means they feel exactly the same as they did before their hemorrhage. No symptoms, no headaches, no fatigue or anything. And so I think that's actually quite remarkable. When I ask my colleagues what percentage of patients do you see back with subarachnoid hemorrhage who say they feel the same as they did before the hemorrhage, and most people say about 5%. So there are actually quite a few patients who do very well. And that being said, well, what do we do? According to the American Heart Association, there's only 2 interventions that have class 1 evidence or backing for them, and those are oral nimodipine administered to all patients and repairing the aneurysm either by clipping or coiling early on, although time is not exactly specified. All of the other things that we do in the intensive care, for example, euvolemia, maintaining the hemoglobin at some level, blood pressure control, monitoring, treatment of vasospasm is all based on class 2 to 3 data. Now, that's in part because many randomized clinical trials have been done, and most of those have been negative, and I listed a few here. Some major ones include tranexamic acid, even with the short-term administration, steroids, clazosentan, statins, nicardipine, terlizat, all studied in thousands of patients. There's some evidence from Japan that Fasudil might be efficacious, but that's limited to some of the Asian countries. Now, I think we need to distinguish between, as I said here, negative studies and inconclusive studies. And in fact, while some of those are truly negative, many of the studies that we do are inconclusive, I would say. And that is represented here, where you see, for example, this was the Newton clinical trial that I recently was involved with. The percentage of favorable outcome was about 45% in each group, but you can see the relative risk here. The confidence intervals overlap 1, and they include the possibility of harm or improvement from the drug. Similarly here, you can see the confidence intervals for the point estimate of the outcome, and they're quite wide. So this is an inconclusive study. We didn't show whether it worked or not. We showed there was not much difference, at least in this small number of patients, but this didn't definitively show whether it worked or not, because the confidence interval overlaps one, and it doesn't exclude the possibility of benefit or harm. Now, this issue of negative or inconclusive clinical trials is common to other neurological diseases, as you know, traumatic brain injury, ischemic stroke. And we've thought about reasons why that might be, and I've listed some of them here. Many of our treatments have targeted vasospasm, and there's some opinion that that is maybe not the cause of many of the poor outcomes. Sample sizes of the studies are small, as I showed you, and that leads to overlapping of the estimate of the effects. Insensitive outcome, modified Rankin or the Gauss are not detecting differences, adverse drug effects and things like that. And so about 10 years ago, we thought that we would figure out ways to try to improve outcomes. And we knew that the head injury group were looking at combining data from different studies and making international cooperative groups to study the disease. And so we had the same thoughts for subarachnoid hemorrhage and came up with this idea to pool existing data from randomized clinical trials and SAH registries. And then, first of all, pool the data, and we knew that it wouldn't be the same and we would have to develop CDEs or common data elements. In order to show feasibility, we were going to develop prognostic models and then use that to then conduct clinical trials and comparative effectiveness research. And we had to come up with a mnemonic for our group. This one didn't work so well, so we came up with the Subarachnoid Hemorrhage International Trialist Repository. Currently, we have almost 20,000 individual patient data in that from multiple different studies, and many of you probably contributed some patients to this, and we're always looking for other people who are interested and in contributing data and also in using some of the data to study different aspects of the disease. Now, the first thing we knew was that the studies would classify things differently, and you can see this is a problem that's existed since the disease was first described. And for example, here in 1852, you can see Brunton described the size of aneurysms, and this was back in the food era of classification of things. So classified them as a filbert, which is a type of a hazelnut, I think, or a pea or a walnut size. And then by 1916, you can see Fernsides had sort of partially graduated away. He had some food-sized aneurysms, but then he moved into the quantitative millimeter sizes. But anyway, we found that studies measured aneurysm sizes differently and classified them differently, and we had to come up with common data elements and make just basically recommendations about how to classify things. And these are a work in progress. They're on the NIH website. They're meant to be used and modified and improved over time. The second thing we did was to develop prognostic models for outcome. And this was to show that we could, in addition to having people collaborate and submit data, that we could actually work together and do a project. And the first one was the development of prediction models for outcome. And we initially did that on about 11,000 patients. And then as further data came in from other studies, we were able to validate that on additional patients. The outcome for these studies was mortality or basically favorable outcome, which was classified as a modified Rankin of 0 to 2, or the upper two categories of the Glasgow outcome score, good recovery or moderate disability. And the bottom line was that we found basically with a pretty simple core model, age, whether or not the person had hypertension, and their admission neurological grade. We had an area under the receiver operating curve as of 0.8, and which is pretty good, although adding in other factors, as you see here, a neuroimaging model where we added in the volume of the subarachnoid blood and the aneurysm size and location, doesn't really add much to the AUC. And similarly, a full model including the core, the neuroimaging features, and then the aneurysm repair modality, you can see also doesn't really add much more. So pretty basic factors are all that we need to predict the outcome right now. And with further ones, it's hard to demonstrate any more accuracy. And we published that in the BMJ, and we made a website with a scoring system, which is not running right now. I need to get that going, but basically you would enter your core variables here. So 50 would be the age of the patient, no would be hypertension, 2 would be their WFNS grade, and you could just do the core, or you could add in then aneurysm size and location and the full model clip or coil, and it'll tell you then here the chances of mortality, so here, and the mortality and unfavorable outcome for neurocharacteristics, or I think this is the core model. And the interesting thing is that the confidence intervals are just disappointingly high. So even though 35% was estimated to be the unfavorable outcome in this particular patient, you can see the confidence intervals there are somewhere between 7 and almost 80%. So it shows you that we're not using those factors, even though they're the ones that become significant in the model, the logistic regression model. We're actually pretty rudimentary in our ability to accurately depict outcome, and we explain only about a third of the variation in outcome with those factors. So having done that and making the common data elements, we are now in the process of trying to get sites and money for funding of prospective data collection and comparative effectiveness research. And so what else can be done to improve outcome? Probably the initial thing would be aneurysm repair. And as you know, rebleeding, of course, is the thing to prevent, and that can be mainly definitively done by clipping or coiling the aneurysm. So it's still a problem. Here's an example of a person that we had in years ago in Toronto, hemorrhaged at an outside facility, blood pressure a little bit high, small hemorrhage here to begin with, and then rebleeds and comes down, has surgery, and ends up disabled from this hemorrhage. Many people die from rebleeding. The difficulty is that according to Germans here in a paper a number of years ago, if you look carefully, rebleeding is more common than the traditionally cited number, which we used to be taught was 4 or 5% within 24 hours. You can see that with carefully studied patients scanned early after the hemorrhage, they found that 15% of patients rebled, and the median time was 3 hours. So that means that if you want to prevent those rebleeds, you're going to have to be treating these patients very quickly. It suggests to me that you need early or emergent aneurysm repair. And there, of course, 10 years ago, there wasn't the sort of precedent in stroke for this kind of thing. But nowadays with thrombectomy trials where we treat patients within 30 minutes routinely, the possibility remains that we could do emergent aneurysm repair and maybe make an impact on rebleeding. Otherwise, of course, we rely on reducing the blood pressure, which is of minimal, obviously some, but not that much importance, actually. I'm not going to talk about intensive care, but the other factor, of course, that we focus a lot on in the management of these patients is delayed ischemia and angiographic vasospasm. Now, as I said before, we've done many clinical trials and not found treatments that reduce vasospasm necessarily have improved outcome. And that's because, as shown here, as early as 15 more years ago, Broderick showed that the vast majority of causes of death following subarachnoid hemorrhage were not due to vasospasm, but you can see 60% due to the initial bleeding, and then rebleeding another 25%. So vasospasm is a very rare cause of death. Of course, it does cause mortality or morbidity, but that's also been reduced with modern management. I'm not going to go into the definitions here. We know angiographic vasospasm then refers to the CT or angiographic appearance of the blood vessels. Delayed ischemia is the clinical consequences, and infarction is the thing that's strongest linked to poor outcome. Now, we used to say that subarachnoid hemorrhage caused angiographic vasospasm, which it undoubtedly does, and then that leads to focal infarctions and poor outcome. The thinking now is that there are multiple other things that the subarachnoid hemorrhage does, and that the ischemia that occurs at the time of the hemorrhage cause, including cortical spreading ischemia, microthromboemboli, microcirculatory changes, and things like that. And all of that sort of contributes to the delayed ischemia and poor outcome. And so targeting angiographic vasospasm alone may not be enough to detect improvements in outcome. Now, this is not new. You can read back, for example, in 1982, Mendelow did one of the first randomized trials in subarachnoid hemorrhage with aspirin. So they were thinking about thromboembolism back then. And in the British nimodipine study in 1989, in the discussion talking about other factors other than arterial narrowing leading to ischemia. That being said, in this data that we had from another clinical trial where every patient had a baseline and a follow-up CT scan and a quantitatively measured angiogram, you can see that delayed infarction is only occurs, or vasospasm, severe vasospasm, is necessary for infarction. You can see if you don't have severe vasospasm, then you rarely have infarction, less than 10% of patients, whereas it's not sufficient. In other words, if you have it, you might get an infarction, but many patients get through the phase of severe angiographic vasospasm without at least a detectable infarction. So that means other factors are involved, which, as I said, we've known for some time, both microcirculatory changes, cortical spreading ischemia, contributions of hypotension, systemic things, etc. Now, what do we do about a person who gets DCI or delayed cerebral ischemia? Most of us use induced hypertension. It's only been studied in this one randomized trial, which was stopped because of slow recruitment. And you can see it was inconclusive, as I mentioned earlier, about many studies. So the risk ratio for poor outcome was 1 with wide confidence intervals, and the adverse events 2, twice as high with induced hypertension, again, broad confidence intervals. In about half of the patients, they did cerebral CT perfusion studies and found that they didn't significantly improve the cerebral blood flow with induced hypertension, which would be contrary to the teaching of what induced hypertension does, which should increase blood flow in areas with impaired autoregulation and ischemia. So why was that study inconclusive? Well, small numbers, but my feeling is that induced hypertension probably has some benefit, but in that study, for example, and in most of them, we don't have a good way to diagnose DCI, in which cases there has to be a reduction in blood flow. Otherwise, it wouldn't be an ischemic basis. And so those are the only patients that are going to benefit from induced hypertension. And if we don't select out those and we treat a bunch of other patients who don't have low perfusion, then we're not going to necessarily detect any benefit. And the other rescue therapy that's widely used in the US particularly is mechanical or pharmacological angioplasty. And the guidelines say that this is, for example, reasonable to use or may be considered. And the problem that I have with it is that usually in a treatment like this where you have sort of retrospective single center series reported, there's a marked benefit of the treatment. And then the benefit tends to be less when you do a proper randomized clinical trial. And yet for this treatment, you can see in this forest plot, looking at multiple different studies, the diamond, which represents the mean and the 95% confidence intervals, is on 1, which means even in these retrospective single center mostly studies, you can't even demonstrate a benefit for mechanical or pharmacological angioplasty. So this is another thing, in addition to induced hypertension and selecting patients for that treatment, this is another, I think, aspect of treatment that we could study further to determine if it works and if it works in some subpopulation of patients. So in conclusion, I think further improvements in outcome could be potentially realized by doing emergency aneurysm repair, or at least studying that, and by looking at rescue therapies, induced hypertension, angioplasty, and that randomized trials for these things, as I mentioned, for rescue therapies, for example, people don't want to randomize. They think these things work already in some places and other people don't. And these are more probably better studied by a comparative effectiveness approach rather than randomized clinical trials. So I'll stop there. Thank you.